ultrasound techniques, pitfalls, and common pathology. Shoulder ultrasound is a medical imaging technique that uses sound waves to produce real-time images of the structures within the shoulder joint. It is a safe, non-invasive procedure that is highly effective in diagnosing cases of the soft tissues, bones, and fluid structures of the shoulder. It is a valuable diagnostic tool that can be applied readily to determine the cause of shoulder pain. Its low price, high diagnostic accuracy, and capacity for dynamic evaluation are additional benefits. To evaluate all potential causes of shoulder pain, it is preferable to follow standardized protocol and perform a thorough evaluation of the shoulder. In addition, a thorough dynamic study can improve the diagnostic accuracy of the ultrasound, particularly when the pathology is not revealed by a static evaluation. It is important to keep in mind that even though ultrasound can be helpful for many shoulder problems, there are times when other imaging methods, like magnetic resonance imaging or the MRI, may be better. Your doctor will decide which imaging method is best for you based on your individual symptoms and medical history. The shoulder's musculoskeletal anatomy consists of bones, joints, muscles, tendons and ligaments, and other structures that provide stability, mobility, and strength to the shoulder complex. Here is a concise overview of the principal musculoskeletal components of the shoulder. The upper arm bone that creates the head of the shoulder joint is in the shape of a ball, also known as a shoulder blade. The scapula forms the rear of the shoulder and serves as an attachment point for tendons and muscles. The clavicle, also known as the collarbone, connects to the shoulder to the sternum and the breastbone and aids in shoulder joint support. The major shoulder joint created by the articulation of the humeral head and glenoid cavity of the scapula. It allows a broad range of motion at the expense of stability. Four muscles of the rotator cuff: the supraspinatus, infraspinatus, teres minor, and subscapularis, that assist in stabilizing and moving the humerus. Tendons of four rotator cuff muscles that attach to the humerus and stabilize the shoulder joint. Attached to the tip of the glenoid cavity, this tendon of the biceps muscle assists in arm flexion and rotation. The glenoid labrum is a fibrous cartilage ring that provides shoulder joint stability by enlarging the glenoid cavity. Other structures are the bursa, which is the fluid-filled sacs located between the tendons, muscles, and bones that aid in reducing friction and promoting seamless shoulder movement. Shoulder ultrasound can be utilized to evaluate and diagnose shoulder problems in a variety of clinical settings. These are the most prevalent pathologies diagnosed by ultrasound. Common indications for performing an ultrasound on the shoulder include shoulder pain, may be caused by, among other things, the rotator cuff injuries, tendinitis, bursitis, impingement syndrome, or arthritis, which can be diagnosed with an ultrasound. Utilizing ultrasound technology rather than radiation, ultrasound of the shoulder can be highly effective in diagnosing diseases. Performing an ultrasound on the shoulder requires multiple stages to obtain high-quality images and evaluate the shoulder structures accurately. Step 1 is for the long head of the biceps brachii tendon. The patient should be seated securely with his or her shoulder exposed and easily accessible. Proper patient positioning is very crucial. Using a linear probe, gently put the probe in the patient's shoulder in short axis. Place the arm in a slight internal rotation with the elbow flexed 90 degrees and the palm facing up. Locate the long biceps tendon between the greater and lesser tuberosities to begin. Shift the probe upward to investigate the interarticular course of the biceps. The transducer is then turned 90 degrees to see the long axis of the biceps. The biceps tendon is checked for problems like tendinosis and tendon tears. Joint fluid or tenosine synovitis in the area around the tendon are also looked for. Next step would be for the subscapularis and biceps tendon. Rotate the arm externally while securing the elbow to the iliac crest in order to visualize the subscapularis tendon and its insertion at the lesser tuberosity. Next step is for the supraspinatus tendon. Place the patient's arm posteriorly, palm side of hand on the superior aspect of the iliac weak, elbow flexed and directed posteriorly. It is necessary to evaluate the supraspinatus tendon along both its long and short axis. It's important to remember that rotating the proximal humerus will change how the supraspinatus tendon is positioned and as a result, the image plane. Next step is the infraspinatus and teres minor tendons. Place the transducer over the posterior aspect of the glenohumeral joint with the hand on the opposite shoulder and increase the depth to include the posterior fossa structures within the field of view of the ultrasound image. The two tendons are distinct structures originating from their respective muscles. The yellow marking indicates the infraspinatus tendon, and the green marking indicates the teres minor tendon. Trauma is the most prevalent cause of labral pathologies of the glenohumeral joint. It is essential to visualize the anterior and posterior labrums, as multiple fractures and injuries can occur in this area. To find the acromioclavicular joint, you only need to feel the collarbone and move the transducer in the coronal body plane laterally towards the acromion. To determine the presence of the disease, move the transducer anteriorly and posteriorly across this joint. Check the acromioclavicular joint for problems with the bones, subluxation, or growth. The normal acromioclavicular joint space is within 0.3 to 0.8 centimeter. If the acromioclavicular joint is wider, or if there is a clinical evidence of acromioclavicular joint dislocation, alignment changes should be checked using the dynamic evaluation. This is the dynamic evaluation for impingement. First, locate for the biceps tendon. Then ask the patient to move the hand laterally. Smooth movement of the tendon and humeral head should be evident. If this is not the case, signs of impingement may be considered. There are various potential hazards or challenges that sonographers may face when doing a shoulder ultrasound. These issues can have an impact on image quality as well as diagnostic accuracy. Anisotropy is the phenomenon that an ultrasonic beam affects tissues in different ways based on how it hits them. It can give wrong or uneven results, especially when tendons are being looked at. You can lessen this effect by changing the angle of the probe, rocking the transducer, or by using dynamic scanning methods. Improper patient positioning can have an impact on image acquisition and quality. It is critical to place the patient in a comfortable and ideal position that allows proper access to the shoulder and adjacent tissues. Accurate transducer placement is critical for producing high-quality pictures. Poor transducer location or angulation might lead to inadequate visualization of the target structures or introduce artifacts that can be difficult to comprehend. To avoid these difficulties, sonographer must have an adequate training and expertise in shoulder sonography, adhere to standardized protocols, employ dynamic scanning techniques, and interact with doctors to guarantee a thorough evaluation of the shoulder. There are also some limitations when utilizing ultrasound of the shoulder. These limitations include improper patient positioning that can have an impact on image acquisition and quality. It is critical to place the patient in a comfortable and ideal position that allows proper access to the shoulder and adjacent tissues. Patient participation and the capacity to relax the muscles can have an impact on the scanning procedure. Infections and fractures. These conditions can cause pain and can affect arm mobility, thus limited patient positioning. Implants can cause artifacts that can impede the optimal diagnosis of the shoulder joint disease. That would be all, and these are my references. Before my lecture ends, I would like to acknowledge my bosses for the support in making this presentation possible. Dr. Eugene Lee, the head of the Department of Radiology, Philippine Orthopedic Center, our Chief Radiologic Technologist, Mr. Generlito Casaje, and to our advisors and radiologists, Dr. Mylene Mendoza, Dr. Patrick Balolong, and Dr. Irene Bandong. Thank you very much.
Thank you, Feliz. Now, allow me to introduce to you our second speaker. Our second speaker is Maria Teresa D. Zapata. She finished Bachelor of Science in Radiologic Technology from Martinez Memorial Colleges, Caloocan City. She's been into ultrasound practice since 1999 and has been working as a Radiologic Technologist 1 in the Philippine Orthopedic Center Radiology Section since 2018. Her topic is about common breast nodules in ultrasound.
Good evening, everyone. I am Maria Teresa Zapata from Philippine Orthopedic Center, Radiology Department. Our topic for tonight is about the common breast nodules in ultrasound. Indications for breast ultrasound. Evaluations of masses found on mammography or for palpable masses. Allow us to obtain images in almost any orientation. Especially useful in patients with dense breasts, which is common in younger women. Masses in patients with dense breasts are difficult to detect in mammograms. It can also be used in guided interventional procedures of the breast. Screening tool for women under 30 with high risk for developing breast cancer or in patients presenting with palpable breast lump, dense breast, pregnant or lactating patients, and patient who has undergone breast augmentation. This image shows an example of a normal breast anatomy in ultrasound. We can see the mammary layer, the retromammary layer, the pectoralis muscle, and the rib. Breast mass characteristic. Benign lesions usually have smooth, rounded margins. Malignancies are aggressive and tend to grow through tissue via speculation. Speculation, finger-like extension of a malignant tumor usually appears as a small line that radiates outward from margin of mass. Speculated margins are the ultrasound finding with highest positive predictive value of malignancy, typically alternating hypoechoic and hyperechoic lines. As you can see, this is an image of a mass with speculated margin. You notice there is a sign of finger-like extension of a malignant tumor. Shape: benign. Rounded or oval shape is usually associated with benign lesions. Mild undulations in contour. Malignant. Sharp angular margins are associated with malignancy. Microlobulations. Smaller, sharper, and numerous. Internal echo pattern. Benign. Isoechoic with breast parenchyma or hub echoes equivalent to or brighter than the path. Malignant. Hypoechoic, weak internal echoes, dense posterior shadowing, making the lesion difficult to penetrate. Microcalcifications within the mass. Mobility, compressibility, and vascularity. Benign. Limited degree of mobility but may roll when palpated. Somewhat compressible. Malignant. Fixed and rigid, zero mobility, non-compressible, or hard. Vascularity. Malignant masses will often demonstrate increased vascularity with the lesion and often had a feeder vessel. Breast cysts, commonly seen in women 35 to 40 years of age. History of cysts changing with menstrual cycle. Pain occurs when cyst grows rapidly. There are two types of cysts, the galactosile and sebaceous cysts. Galactosile. It is milk-filled cyst located beneath the areola. Results from obstruction of lactiferous duct. Aspiration can relieve symptoms, but most resolve spontaneously. Fibroadenoma. Most common breast tumors occurs in 20 to 30 years of age. Firm, smooth, rubbery, hard lump with well-defined shape. Move easily without pain. Ranges from 1 centimeter to several centimeters. May get bigger during pregnancy and breastfeeding. Normally grows very slowly, but a sudden increase in size might indicate a hemorrhagic cyst. Fibroadenoma, a benign tumor and usually painless. It is hard, round lump with a smooth and well-defined border that moves easily under the skin of the breast. This is an example of a fibroadenoma with a smooth and rounded margins. It has a low-level homogeneous internal echoes. Fibrocystic conditions or lumpy breast. Glandular breast tissue involvement. Rather than slapping away each month, these cells become apoptotic, which results in scarring or fibrosis. Lumpy breasts, these are cysts which are fluid-filled sac which is round, smooth, and firm. A breast cyst can range in size from a few millimeters to as large as a golf ball. It can be monitored because it may appear before the period and become smaller or larger and may even disappear after a woman period. This is an example of a multiple cyst or a lumpy breast in ultrasound. We can see and anechoic structures within the breast. Lipoma. It occurs in a middle-aged or menopausal woman. Large, soft mass with irregular borders, not able to be separated from the surrounding tissue. Difficult to see with ultrasound. Typical smooth walls, echogenicity, same as fat and is compressible. Lipoma is a fatty tumor located just below the skin. It is a slow-growing fatty lump that most often grow between the skin and the muscle layer. Breast abscess mostly occurs in breastfeeding due to cracked nipples, overweight women who smoke with large breasts. Borders are initially poorly defined but become well encapsulated as the abscess matures. Edema of the surrounding tissue. Breast abscess, it is an accumulation of a pus caused by infection, usually occur from breastfeeding and must give a medical attention. Intraductal papilloma, small benign tumor within the acini. Women 35 to 55 years of age. Spontaneous nipple discharge, usually small, multiple, and multicentric. Simple proliferation of duct epithelium projecting outward into a dilated lumen. Intraductal papilloma, it is where an abnormal cell occurs in the lining of the breast duct. The cell have not spread outside the duct or in the other part of the breast. Infiltrating ductal carcinoma, most common type. Spread to surrounding breast tissues, can spread to lymph nodes. Infiltrating ductal carcinoma, this is a type of breast cancer that starts in the milk duct of the breast and may spread through the lymph nodes. Symptoms of breast cancer. New lump in the breast or underarm, thickening or swelling of part of the breast, irritation of breast skin, redness or flaky skin in the nipple area, pulling in of nipple, and pain in the nipple area. This is a case of a female patient, 62 years of age, with palpable mass and inverted nipple. Findings: large oval lobulated solid right breast mass with shadowing. Tissue correlation is recommended. That's all, and thank you, everyone.
Thank you, Ms. Zapata. Our third speaker is Maria Jorilisi Mercado. She graduated BS Radiologic Technology from the Family Clinic Incorporated in 2016 and completed her Master's in Management and Public Administration at the Philippine Christian University in 2022. She has been part of the Philippine Orthopedic Center since 2016 to present, performing diagnostic procedures, image quality control, performs ultrasound, CT scan procedures, and she has received trainings on vascular ultrasound imaging from the National Kidney and Transplant Institute and general ultrasound from Chinese General Hospital and Medical Center. Also, training on quality management in radiology and QA/QC on digital and computed radiography from the Philippine Children Medical Center. To give us a lecture on FAST versus eFAST in trauma, let's welcome Maria Jorilisi Mercado.
Good evening to everyone. I am Maria Jorilisi Mercado and I am a radiologic technologist from the Philippine Orthopedic Center. I've been working here for over 8 years and as of the moment, I am currently assigned in the emergency room X-ray department of our hospital. So my presentation for tonight is all about fast versus e-fast for trauma. So first of all, what happens in the emergency room? I would like to start by having an overview of what happens in the ER. In our line of work, we serve over 100 patients every day, and as a result, most of our patients' conditions are typically bad. They commonly arrive in shock or with numerous injuries, and drinking and having head trauma also have an impact on their mental state. Due to this, our patients frequently suffer from distracting injuries, which further complicates the attempts to determine their injury pattern only through physical examination. So when a patient comes with severe injuries, the doctor in charge usually requests for a fast ultrasound examination for the patient. The common indication for this is when the patient has blunt penetrating cardiac, pelvic, and abdominal trauma. So again, I would like you to know that FAST means focused assessment with sonography for trauma. It is a non-invasive test that can be done rapidly. It evaluates for the presence of intraperitoneal free fluid in the abdomen and pelvis. In addition, cardiac views allow for detection of cardiac injury and pericardial effusion. So as a radiologic technologist, we frequently perform the fast ultrasound first, which may be finished in less than 5 minutes, and it is intended to be done quickly and precisely. After the examination is complete, the radiologist reviews the images and runs a second scan to confirm the results. So in performing the FAST examination, we need to evaluate the four regions of the abdomen. First, the cardiac subxiphoid. Second is the right upper quadrant or the hepatorenal. Third is the left upper quadrant or the splenorenal. And the fourth one is the suprapubic views or the pelvic area. So in this slide, it shows how you will position the probe when you are performing the cardiac subxiphoid view. Place the probe just inferior to the xiphoid process with the indicator toward the right and angle it up toward the left shoulder. This view helps to determine for cardiac tamponade and can also be used to evaluate for cardiac activity in cases of traumatic cardiac arrest. So I have here an example that shows a negative cardiac view, and I have also here an example that shows a positive cardiac view. We have here the yellow line, and it represents the fluid. And I have also here the blue arrow that represents a clot sealing penetrating wound in the right ventricle. These slides illustrate how the probe should be placed while doing the right upper quadrant or hepatorenal view. Place the probe in the right anterior to mid-axillary line between the 7th and 8th interspaces. Utilizing the liver as the sonographic window, this view evaluates any potential space between the liver and kidney in the right upper quadrant. Additionally, it evaluates the areas directly above and below the diaphragm, as well as the top section of the paracolic gutter on the right. So I have here an example of a negative or a normal right upper quadrant hepatorenal view. The yellow arrow represents the liver, while the blue arrow represents the right kidney. This second picture shows a positive scan of the right upper quadrant hepatorenal view. The yellow arrow represents the free fluid in the Morrison's pouch, and I would like everyone to know that Morrison's pouch is the space between the liver and the kidney. We also have here the free fluid in the chest cephala to the diaphragm and may be considered as hemothorax. So I have a short clip here that shows that there's a free fluid in the Morrison's pouch in the subhepatic space. This type of image is considered a positive hepatorenal view. This slide demonstrates where the probe should be placed when scanning the left upper quadrant splenorenal view. Place the probe in the left posterior axillary line between the 7th and 8th interspaces and fan through the entire interface of the spleen and the left kidney. Using the spleen as the sonographic window, this view evaluates any potential gap between the kidney and the spleen in the left upper quadrant. Additionally, it evaluates the areas immediately above and below the diaphragm as well as the left upper paragolic gutter. I have here an example that shows a normal scan of the left upper quadrant splenorenal view. The yellow arrow represents the spleen and the blue one represents the left kidney. The next clip shows a positive scan of the left upper quadrant splenorenal view. The yellow arrow shows a free fluid in the spleen. So this slide demonstrates how to position the probe in the abdomen's suprapubic region. Using the bladder as the sonographic window, this view evaluates the pelvis for free fluid. Place the probe just above the pubic symphysis and aim towards the feet, fanning through the bladder in both longitudinal and transverse orientation. This picture shows the pelvic anatomy when we are conducting the FAST examinations. For female patients, free pelvic fluid will first be seen in the cul-de-sac posterior to the uterus. Larger amounts of fluid will collect behind the bladder, both anteriorly and posteriorly to the uterus, while for male patients, free pelvic fluid will be seen in the retrovesical space. This picture shows a negative suprapubic scan of a female with no significant free fluid seen. The yellow arrow shows that there is an intrauterine device inserted, while the blue arrow represents the bladder. The next picture shows a positive suprapubic view of a male patient. This image includes a double wall sign. It is frequently used to characterize a male with a positive pelvic FAST. Urine will illuminate the inner bladder wall, whereas free fluid outside the bladder will illuminate the outside bladder wall. So the yellow arrow represents fluid and the blue arrow represents the urinary bladder. So I have here a sample video when you are scanning the patient's suprapubic area. The first video shows you when you're tilting the probe in the transverse view. It is when you tilt or fan the probe to examine the entire pelvic from superior to inferior. While the other one is when you're tilting the probe in the longitudinal view. In all patients, male or female, observe the lateral borders of the bladder to identify free fluid by tilting or fanning the probe left and right. I have here a case of a 12-year-old male. He came to our hospital severely injured and got hit by a 10-wheeler truck. After the initial assessment of the doctors in the triage, we conducted a fast examination for the patient. The first image shows the liver and the right kidney, and the next image shows the hepatorenal scan. The arrow represents the fluid in the Morrison's pouch. And in this image, it considered as a positive hepatorenal scan. Next is the image of the spleen and the left kidney. The green arrow shows minimal fluid between the spleen and the left kidney again. This scan represents a positive splenorenal scan. This image represents the suprapubic area. As you can see, there's a free fluid beside the urinary bladder. And again, this is a positive scan of a suprapubic or the pelvic scan. We also took ultrasound images of the right and left lower quadrants, and free fluids are seen in this area. As the radiologist advice is to go for a CT scan for better evaluation. Now, for EFAS, it means Extended Focus Assessment with Sonography for Trauma. The protocol is just the same, except that we added the lungs in the examination. The EFAS evaluation provides critical information during the real-time evaluation of complex trauma patients. It can identify free fluid suggestive of abdominal solid organ injury, hemothorax, or pericardiac fluid collections. The common indications are hemothorax and pneumothorax. For hemothorax scanning techniques, move the probe superiorly 1 or 2 rib spaces to evaluate the thorax for fluid accumulation. This should be done on both right and left lung. The image shows a normal right pleura that shows no collections of free fluid. This first image shows a normal right pleura that shows no collection of free fluid. The following image displays a sample of a hemothorax. The yellow arrow points to a buildup of free fluid. I have here a sample video wherein there is a free fluid in the thorax since ultrasound waves can easily pass through the free fluid in the chest cavity. So this is an example of a positive hemothorax scan. For pneumothorax scanning techniques, begin in long axis orientation, then swivel probe to short axis. The positions taken are the anterior and lateral chest views. This slide shows the probe placement for right and left lung. The anterior pleura is assessed for the presence or absence of a lung sliding as a sensitive but non-specific indicator of a traumatic pneumothorax. The probe is placed in a sagittal orientation in the midclavicular line between the clavicle and the diaphragm. The most helpful sign to rule out pneumothorax is the sliding lung sign. I have a clip showing the normal lung sliding in B mode. Beside the pleural line is the rib shadow. As you can see, there's a movement in the pleural line. The next thing to do is take an image with the M mode to check for the seashore sign. Everything above the pleural line is relatively static. This is where intercostal and muscular segments are located, but it is mostly straight line because it is all relatively static. You can observe the movement of a normal lung sliding because the area below the pleural line is relatively dynamic. In the slide, to confirm the presence of pneumothorax, you should look for the lung point sign. The lung point is when you can see the transition between normal lung sliding and the absence of lung sliding. This is the transition point between the collapsed lung and normal lung. The lung point sign also helps you quantify how large a pneumothorax is. If you think you may have found a lung point but are not sure, use M mode and place your cursor at the intersection where you think lung sliding starts and stops. If you see a normal seashore sign that turns into an abnormal barcode sign, then you have located the lung point with an M mode. In some instances, performing fast examination have false positives and negatives. For fast false negatives, the reasons are obesity, because it severely limits assessment of the peritoneal cavity. Next is subcutaneous emphysema and posterior acoustic enhancements caused by the fluid-filled bladder that can result in free fluid being missed in the pelvic view. While in the fast false positives, the causes are epicardial fat pads, the descending aorta, and pericardial cysts have been mistakenly identified as an effusion. Next is pre-existing ascites, pleural and pericardial effusions due to medical conditions, and seminal vesicles mistaken for pelvic free fluid in the young male patient. So that concludes my presentation. This is the end. However, before I end this, I would like to acknowledge the support of my bosses, Dr. Eugene C.D., the head of the Department of Radiology of Philippine Orthopedic Center, Mr. Henrylito R. Casahe, our Chief Radiologic Technologist, for the support and guidance, and to my advisors for this presentation, Dr. Irene S. Bandong, Dr. Patrick Balolong, and Dr. Mylene Mendoza. Thank you all very much. Thank you for the support. And to my co-radiologic technologists in the hospital, thank you all again very much. Thank you.
Thank you, Ms. Mercado. Moving on, let's have our fourth speaker. She is Regina Angelica Almazar. She finished Bachelor of Science in Radiologic Technology from the College of Our Lady of Mercy, Pulilan Foundation Incorporated, Longs Pulilan, Bulacan, in year 2018. And since then, she has worked as a radiologic technologist in Malolos providers, health providers, and later in Allied Care Experts Medical Center, where she handled CT, MRI, and ultrasound equipments. Currently, she is an instructor and Dean of Allied Health Sciences Department of Our Lady of Mercy Pulilan Foundation Incorporated. To discuss about nutcracker syndrome in ultrasound, let's welcome Regina Angelica Almazar.
Good evening, ladies and gentlemen, and welcome to the 26th CPD Asia. I'm Regina Angelica Almazar, an ultrasound technologist. Allow me to share my personal experience in imaging NCS utilizing ultrasound. 2 years ago, a 16-year-old male patient presented with a flank and abdominal pain at the institution I was employed in. Fortunately for me, I was tasked with performing whole abdomen ultrasound scan on the patient. That day, I stumbled across an uncommon view of the left renal vein. Subsequently, the radiologist concluded the diagnosis to be nutcracker syndrome, a rare condition which we will discuss in further detail. The following are the goals that are intended to be achieved in this learning experience. So the primary objectives are to learn the renal blood supply, the renal vessels in ultrasound, nutcracker syndrome causes and symptoms, and the features of nutcracker syndrome in ultrasound. All right. So the aorta is a cane-shaped artery. It starts in the lower left chamber of your heart. The aorta is the major vessel that leaves the heart to get the bulk of blood to the rest of the body. And the aorta goes down through the thoracic region down to the abdominal region. Now we're looking at the abdominal aorta. There are blood that is coming through or coming down the abdominal aorta, then we have those two short paired arteries that arises from its lateral aspect. The renal artery. The renal artery or the artery supplies the kidney parenchyma with oxygenated blood and simultaneously delivers the blood to be filtered by eliminating the metabolic waste and the excess water and reabsorbing the minerals and nutrients. So the artery is going to split to go to different sections or segments of the kidney. And that's why those are called the segmental arteries, followed by the further branching to form the interlobar arteries, which pass through the renal columns. At the basis of those pyramids are the arcuate arteries that gives its name to arc or arcuate arteries, branch from the interlobar arteries and then enter those lobes. The small arteries and arterioles from the arcuate arteries will send the blood to the interlobular arteries. So from the renal artery, it split to become the segmental artery, and then it became the interlobar artery, and then arcuate artery. So don't be confused with interlobular arteries, as it was also known as the cortical radiate artery. From the interlobular arteries, it will send off through tiny branches, and those are called the afferent arterioles. And from the afferent arteriole is the glomerulus. So this is the time that the nephrons are supplied by the blood. So the nephrons are the functional units of the kidney. The peritubular capillaries, the efferent arterioles take the blood from the glomerulus into an extensive network of capillaries called the peritubular capillaries. And those that travel alongside the loops of Henle are called the vasa recta capillaries. The venous returns. Okay. Analogously to the arteries that bring blood to the kidneys, the veins have been given those similar names. So from the peritubular capillaries, it will go down to the interlobular veins, then to the arcuate veins, then the interlobar veins, through the renal veins, back to the inferior vena cava, and back to our heart. All right, so right now, let's proceed with renal ultrasound. So what are the key points in scanning the kidney? Okay, so the kidneys lie obliquely with the left about 2 centimeters higher than the right side because of the presence of the liver. The normal longitudinal scan length of the kidney is 9 to 12 centimeter, and the lengths should not differ by or greater than 2 centimeter. The cortical thickness is 1.5 centimeter to 2.5 centimeter, and it thins with age. The renal arteries arise from the aorta, just inferior to the superior mesenteric artery. The cortical echogenicity is normally slightly lower than the adjacent spleen or the adjacent liver. So here is the ultrasound image of the kidney. So right now we can see the poles of the kidney. It is divided into three poles: the superior, the mid, and the inferior pole. And on our right side is the left kidney and its and the spleen. So, as we have said earlier, that the spleen is um, hyperechoic than the left kidney. Nutcracker syndrome is vascular compression disorder. It results in the compression of the left renal vein as it courses in between the aorta and the superior mesenteric artery. Why is it called nutcracker syndrome? So the condition has this name because the compression resembles a nutcracker cracking a nut. So as we can see here, the left renal vein uh, is in between or shall pass in between the SMA and the aorta. So here's the aorta, and then here's the superior mesenteric artery, and here's the renal vein, the left renal vein. The causes risk factors of nutcracker syndrome. The number one factor is the change in blood vessel anatomy, and it can happen inside the womb, or weight loss, the growth spurts, and also the changes are also the prevalence in female is greater than male. So the teens are usually much prone to nutcracker syndrome. The clinical presentation of the NCS. So for the clinical presentation, the left flank pain, pelvic pain or hematuria, pelvic congestion syndrome or the PCS, and gonadal varices. Gonadal varices happens because of its proximity. The gonadal vein is near to our LRV or the left renal vein, and it can also cause compression. Blood flow backward into the other veins because of this compression, causing an increase in pressure. So it can cause venous hypertension. Sonographically, you'll see a small angle from the SMA to the aorta with a normal angle range of 38 to 65 degrees. So here in the picture, it is less than that degree. So it's 18° only. So it is determined that there is a compression in the left renal vein. Also, qualitatively, we can describe this picture on our right side that there is a compression of the left renal vein. Yeah. Here above is the SMA, and below is the abdominal aorta. Color Doppler NCS. So if we utilize the Doppler technique in ultrasound, we can also specifically uh, predetermine that there is a compression, because as we can see here, there is a dilatation in the left renal vein in its latter part. All right. So nutcracker syndrome versus the nutcracker phenomenon. So nutcracker syndrome refers to the phenomenon when it occurs with symptoms. And in this case, the compression of your renal vein causes symptoms you notice, which may greatly disrupt your daily life. And in nutcracker phenomenon, there is the anatomy but without symptoms. We can see it in ultrasound or other diagnostic imaging procedures, but there are no symptoms. Anterior NCS versus the posterior NCS. Retrocaval, or also called the posterior NCS. What we have discussed earlier, the compression between SMA and the aorta is the anterior NCS. And for the posterior NCS, when the left renal vein goes posterior than the IVC, as we can see here in our CT scan image, it gets compressed by our aorta and our spine. So that's all, and here is our my references. Thank you so much for listening.
Thank you, Ms. Regina Almazar. And finally, to introduce now our fifth and last speaker, she is Patricia Ann A. de la Cruz. She graduated Bachelor of Science in Radiologic Technology from Emilio Aguinaldo College. She has worked as a Health Program Officer 1 in the Department of Health, and currently she is a Senior Radiologic Technologist in the Breast Clinic of the Radiology Department of Makati Medical Center, Makati City. Her topic is mammography advancement, contrast-enhanced mammography.
So good day to everyone. I am Patricia Ann A. de la Cruz, registered radiologic technologist here in the Philippines. So now I'm going to discuss about advancements in mammography, particularly about contrast-enhanced mammography or the CEM. So here is the outline of my discussion. First, we'll discuss how is breast cancer diagnosed. Then about mammography standard procedure, comparison between full-field digital mammography and the CEM. Introduction to CEM, its indications, contraindications, steps involved. Then what are the materials we're going to use? Of course, the steps in conducting CEM, and we're going to show sample cases of contrast-enhanced mammography. So first, how is breast cancer diagnosed? The only breast cancer screening method that has proven to be effective is mammography screening. It is a cost-effective intervention for prevention and control of major NCDs. Mammography is an X-ray imaging tool or method used to examine the breast for early detection of cancer and other breast diseases. So it is used as a diagnostic and screening tool. It is recommended for women ages 40 and above, but it can be done to patients younger than 40 if they have family history of breast cancer and they have symptoms like they have palpable masses or nipple discharge or any pain in their breast. Full-field digital mammography remains the primary imaging tool in breast cancer imaging worldwide. So it plays an important role in breast cancer detection, but it has its limitations like females or patients with dense breast tissue. So to resolve this issue, we have alternatives like digital breast tomosynthesis, breast ultrasound, and breast magnetic resonance imaging. Contrast-enhanced mammography is a combination of mammography and iodinated contrast material administration. So it increased the diagnostic accuracy as compared to full-field digital mammography. So it uses dual energy. An image of the breast is obtained using two different spectra of X-rays. So we have the low energy and your high energy. So it is based on different attenuation coefficients of the tissue and the iodinated contrast. The higher the mass attenuation coefficient, the more X-ray absorption, and the kH of iodine contrast agent is 33.2 kiloelectron volt. So here is an example of images obtained in contrast-enhanced mammography. So we have the dual energy technique. So we have the low energy and high energy. And we will reconstruct the images of high energy and low energy that results to a recombined image. So it's like an iodine map. So you can see there's a contrast uptake here. Then we can eliminate the anatomical noise around the suspicious lesion. So how does contrast enhancement work? So accumulation of the contrast agent in the tissue leads to signal enhancement. The accumulation depends on the physiology, your blood flow, volume percent of extracellular space, the permeability of the vessels or the leakiness. So it works because of differences in contrast agent uptake, then the difference in X-ray absorption. So in healthy breast tissue, it's only grayish in the image. Then if it is a malignant tissue, it will appear bright, or you can see an uptake there, like the image shown here. Tumor angiogenesis is the growth of new blood vessels to provide nutrients and oxygen that tumors need to grow. So here is an example of a tumor. Then it has a vascular and endothelial growth factor here. Then there will be a blood vessel growth since the tumor needs some nutrients and oxygen so that it will grow. That leads to tumor growth. That's why it will have high uptake of contrast. So these new blood vessels have a high vessel permeability or delicatess. The contrast enhanced sonography indications are the problem solving after inconclusive findings on mammography, digital breast tomosynthesis or ultrasound. So it can also be an evaluation of symptomatic patients and preoperative assessment of disease extent. It can also be used for monitoring of patients having chemotherapy or neoadjuvant therapy. Then your post-treatment evaluation of results, screening in intermediate and high-risk patients. That's like what I said, patients that are having symptoms or has family history of breast cancer. Then what are your contraindications for contrast-enhanced mammography? First, patients with allergic reaction to contrast. Then, of course, your pregnant and lactating patients, because we are going to use radiation here. So we need to take extra careful in exposing patients or female patients. We have to ask for their last menstrual period so that we will be sure that they are not pregnant. Needed, radiation protection measures can be put in place to obtain mammograms for these patients. CEM or mammography is possible if it is really needed. So the RADEX will provide, or the radiographers will provide radiation protection measures so that it will be possible for the patient. The next contraindication for CEM is the patients with kidney problems. Before proceeding to CEM, we need to have creatinine results of the patients so that we will know if the patient can undergo a CEM procedure. But if the patient has renal problems, they can consult to their doctors and they need to have a clearance so that we will know if we will encounter any problems with the procedure. Here is an example of a comparison of full-field digital mammography and the CEM or contrast-enhanced mammography. Here we can see the breast tissues. Then here, in our combined image, we can see a high uptake of contrast here on the suspicious lesion. So, as you can see, it really helps in eliminating the unnecessary anatomical noise so that we can see the concern of the patient. So who are the staffs involved? First, of course, your radiographer or the radiologic technologist and radiology nurse if you have in your department. Then, of course, your admin staff or the one who schedules the patient, reminds them of their procedure. And of course, your radiologists because they are the ones to read the images. So preparation in conducting contrast-enhanced mammography, we'll conduct a patient history taking. So patient pays creatinine test results so that we'll know what is the condition of their kidneys because we're going to administer contrast. Next one is taking vital signs of the patients and also their height and weight measurements so that we'll know how much contrast we are going to use. We need to prepare the materials and the power injector if there's any, but having power injectors is highly recommended so that we can customize the flow rate of the contrast. And it also has a preheater so that the condition of the contrast or the quality of the contrast is good. So make sure the procedure area or room is clean. So make sure to disinfect the area every before and after. So here are the materials that we're going to use. So I list it down here. Most of these are what we're going to use in conducting IV insertion. Because we're going to provide IV access so that we can inject the contrast. Steps in conducting contrast-enhanced mammography. First is your test dose. So here we are going to inject a little contrast, maybe about 5 cc of contrast so that we can observe if the patient has any allergic reaction to the contrast. Next, if the patient didn't have any allergic reaction, we can proceed to injecting full dose of contrast with the help of power injector. Wait for at least 2 minutes to allow contrast flow into the breast. So after 2 minutes, you can expose the patient or you can position the patient. We have standard views or standard position, which is the craniocaudal view and the mediolateral oblique. We will start with the affected side or affected breast. For example, if the concern is on the right breast, we will start with or right with CC and MLO view, and if additional views is requested by the doctor, you can also do this. Then we will expose the breast with high energy and low energy. Don't release the exposure button unless it's done, because some retics forgot to hold the exposure button because there are two exposures, the high energy and the low energy. Have the radiologist check the images before discharging the patient. Of course, let the patient rest before discharging and observe for any post-procedural symptoms or allergic reaction. So here are some of the views that are used in mammography. So the craniocaudal, the medial lateral oblique, medial lateral medial. For standard protocols, we use craniocaudal and medial lateral oblique.
Next, let me share with you positioning techniques or best practices in exposing the breast or in mammography. First one, always check your field of view before exposing the part or the breast, because in mammography, we have a limited field of view. Avoid any cutoff so that you will not have any repeat examinations. Next one, as much as possible, nipple should be in profile because it is a landmark or an indication of the mid part of the breast. Next, kindly check for any skin folds to avoid any superimposition in the breast. Put away the patient's hair from your field of view because it can be an artifact to your image. Next one, always be gentle while handling the patient's breast because most of the times it is one of the sensitive parts of the body, especially in women. Another tip is you can use both hands in positioning the patient so that your movement will be more flexible. Next, you can position the patient in upright position so that it is easier to move the patient than in seated position. In craniocaudal view, have the patient lean forward towards the machine so that you can fully pull until the posterior part of the breast. In medial lateral view, make sure to include the inframammary fold so that you will know if you got the lower part of the breast or your lower quadrant. Next and last one, observe the patient for any discomfort and check if you can eliminate or lessen the discomfort of the patient to avoid any motion that can lead to artifact, as well as to provide comfort to the patient and lessen their anxiety.
So here is an example of images obtained using this on your left is the medial lateral oblique and on your right is the craniocaudal view. So here we can see that the pectoralis muscle is seen. So if the pectoralis muscle is seen, you are sure that you got enough breast, or you can see the posterior part of the breast. So here we can see the posterior glandular tissue and your nipple in profile, and the visualization of inframammary fold. So if you have a visualization of inframammary fold, that means you got the lower quadrant of the breast. So in your craniocaudal view, you can see the lateral glandular tissue, the breast, and your nipple is also in profile, which is good. Then you can see the pectoralis muscle here. That means you got the posterior part of the breast. So here you can also see the cleavage of the patient, which means we got the medial part of the breast. One of the artifacts that we can see in mammography is the skin folds. So in proper positioning, we can eliminate this or we can lessen this. So as much as possible, we need to be careful on compressing and positioning the patient. We need to observe if there are any skin folds. So the time window for performing multiple views with a single contrast agent lasts up to 10 minutes. So you have 10 minutes to position the patient and 10 minutes to know if there's any additional views that the doctor is going to request. After these 10 minutes, you may lose the contrast effect. So in our department, we have two RADTechs assigned if there is a CM procedure, so that one RADTech will be performing the positioning, then the other one is in the control console, so that the procedure may become faster or it will make the movements flexible. So to avoid contamination of the detector or the skin with pure contrast agent, care should be taken when having the contrast. It should not be splashed or dropped on the patient's breast because it might mimic calcifications or result in artifacts that can lead to false results or repeat examination. So here are the sample cases in contrast enhanced mammography. So first, we have a low energy image here. So as you can see, there's a circumscribed solid mass. So it is considered virus 3, whilst here in CEM or the combined image, there are no uptake of contrast or there are no enhancing mass. So in CEM, it is now considered as virus 2. So here is a low energy image of CC of both breast. So here is our combined image of the gynecologist view. The patient with breast density grade C was recalled after screening for lesion in the right breast. So the patient's concern was her right breast. Then the enhancement shown in contrast enhanced mammography is on her left. So asymmetrical, mildly enhancing mass, 13 millimeter in diameter, was seen in the contralateral left breast. It wasn't seen in full-field digital mammography, but correlates with the hypoechoic nodule on ultrasound. So its pathology results was an invasive ductal carcinoma grade 2. So another example is intraductal carcinoma. Here we can see in the low energy, there are a lot of breast tissues, and whilst in the combined image, we can see an enhancement here. Also in her CC view, here, then the recombined image, we eliminated the anatomical noise. So another example here is a normal breast. So low energy image shows a dense breast. Then whilst in recombined image shows no uptake in any part of the breast. That leads to a normal result in CM.
So that would be all. Thank you very much for listening. I would also want to thank the breast clinic unit from Makati Medical Center, my colleagues and the doctors for helping me complete this presentation, as well as to Ma'am Chev and Ma'am Abby for the additional references, and to the organizers of the CPD Asia 2023. Thank you very much for having me. Have a good day.
Thank you, Patricia. And now we proceed with the Q&A session. I would like to request all the cameras and the microphones of all our speakers to be open. Kindly unmute your mic if a question is being addressed to you. Also, the session is open now for the panelists to give comments or inquiry or questions to our speakers. So while we are waiting, I think all the speakers have seen already some questions posted in the chat box, but for the benefit of those who are with us, joining us live in YouTube, I'd like to read the question and hopefully to hear again your answers to the following questions. So let me start with a question that came from Kan Fan Joy. The question is, how to differentiate infraspinatus and minor teres tendon in shoulder ultrasound. I think this question is for Feliz Nina. Please help in differentiating infraspinatus and minor teres tendon.
Hi, good day. Infraspinatus originates from the fossa on the scapula, while the teres minor originates from the middle portion of the scapula. They are difficult to differentiate, but the borders can help you differentiate them.
All right, thank you, Ms. Feliz. Another question here is a question for Maria Mercado. So the question is, how do you estimate the volume of free fluid in the abdomen according to FAST protocol?
Hello, good evening to all. Good evening to all those who are watching. So to get the estimate free fluid in the abdomen, we can approximately measure the 3 quadrants, and that is the hepatorenal, splenorenal, and the pelvic area. Thank you.
All right. I'd like also to read a question from Prakash Umbarkar, who's in India. His question is, what is a common challenge that you have experienced performing breast mammography? I think this is for Patricia Ann.
Oh, one of the challenges, hello, can you hear me?
Yes, clear.
I think the challenge in mammography is the positioning because each patient have different kinds of breast. Then they also have different pain management or sensitivity on their breast. So we need to find the correct position or the position of the patient which they can be relaxed, because the standard positions may not be applicable to some patients, and we need to improvise or have alternative to patients that needs another kind of position.
I think, Patricia, this is also a question for you. So the question goes like, is CEM procedure possible for patients with silicone implants?
Yes, it is possible with silicone implants, since it's the same effect. There will be uptake in contrast if there's if there's a suspicious lesion, but in the image we can see the implant which is which appears bright, like it's like white bag. But if it is silicone injection, it is a little difficult for the doctor to read because there will be additional artifacts. But if there is an enhancement, it can be seen on CEM.
Yes, allow me to read some more questions for you. A question is, how does dual energy technique in contrast enhanced mammography help in eliminating anatomical noise?
So dual energy technique helps in eliminating anatomical noise because the high energy captures the highest or the position where the highest uptake of contrast is. Then in your low energy, you can see where the moderate uptake of contrast is. So when you combine these two images, the highlight or the lesion will highlight in the image.
Thank you, Patricia. I have another question here in the chat box, and this is, I think, for Miss Regina. So the question is, in addition to the parameters that you have already discussed, what other ultrasound features can be used to diagnose the NCS?
All right, ma'am. So quantitatively, we can determine if the patient has or suffering from NCS or the nutcracker phenomenon by measuring the anterior posterior diameter of the left renal vein from its comparing its proximal diameter to its distal diameter. So from that, if there is a decrease or an increase of the diameter, we can decide or we can determine if there is a stenosis or if there is a dilatation of the vein. We can also use the feature of renal Doppler ultrasound, and also the flow velocity, comparing the proximal and the distal part of the left renal vein. That's all. Thank you.
Yes, thank you, Ms. Regina. So I have here a question from President Selva Kumar of Indian Society of Radiographers and Technologists. His question is there any protocol for annual check, including mammogram, after 45 years? I think this is a question to those performing mammogram in their institution. Do you have a protocol for annual check, including mammogram, after 45 years? Patricia, do you know about mammogram being part of an annual checkup for women after or in an age of 45 years in your institutions?
In our institution, we do the standard procedures, which is the CC and MLO views. And if there are any suspicious lesion, they will add an additional view.
So is this part of an annual checkup for a woman at age of 45 years old in your institution? Is it part of an annual checkup?
Yes, 40-year-old and
we'd like to know, in a Philippine Orthopedic Center, do you also perform annual checkup exams on women aged 45 years old, which includes mammography?
Hello, ma'am. Usually we don't have mammogram in orthopedic, but from my previous work, here in the Philippines, it is recommended for 40 years old female to go mammogram procedure once a year and then followed by ultrasound for correlation.
All right. Thank you, Miss Maria Teresa and Miss Patricia.
Thank
So yes, I think we have a few more questions here. Here a question is, I think, about FAST for Miss Mercado. Miss Mercado, what do you generally do at your institution? FAST or eFAST? And does a positive FAST requires a patient to be rushed to the operating room as ASAP?
We generally do fast examination during emergency procedures in our hospital. But if the doctors are considering pneumothorax and hemothorax, we typically perform an eFAST combined with a chest X-ray. And then for the second question, that if a positive FAST requires a patient to be rushed in the operating room ASAP, no. A positive FAST does not always mean a patient needs to be rushed to the OR. In many trauma algorithms, a hemodynamically stable patient may still get a CT scan procedure after a positive FAST. Thank you.
Yes, thank you, Ms. Mercado. We have a question from the President of Singapore Society of Radiographers, President Denise Chu. Yes, President Denise Chu, would you like to give directly your question, or shall I read it for you?
Sure, I can ask. I think it's for Miss Felice. Was asking about the anterior labrum in the shoulder. Which approach would be the best to visualize the anterior labrum, and what kind of pathologies will we expect to see in the anterior labrum of the shoulder? Thank you.
Hi, the approach will be the patient will be seated in a chair with the patient is seated in the chair with his or her hand palm side up in a 90-degree position, and the lead rooms are hard to find in the ultrasound, but the anterior lead room can be seen here in the glenoid edge along with the capsulolabral complex. Painful labral tears can also be diagnosed.
Okay, thank you.
Thank you.
Yes, I have another question here. This is from Ho Tien Tan. The question is, can you help differentiate the breast scar and malignant masses?
Hello, ma'am. Usually the breast scar can only be seen in the outward the skin. And then if it is malignant masses, we can see that there are the microcalcifications, or there are speculated margins on the border of the mass. That's all.
Okay, another question here is from Dara Aquino. The question is, why would doctors choose to do CESM if MRI does better breast imaging? For Pat, yes.
Because MRI has a long scanning time, whilst CEM or CSM has a shorter scanning time, and it costs less than MRI. So some MRI procedures are pricey, so they prefer CEM procedures with less cost and less scanning time.
Yes, Miss Patricia, if you happen to also have read, this is, I think, a relative question, a question from Ho Tien Tan. Is it better to do CESM than breast MRI? What's the difference in their sensitivity?
Actually, we can correlate these both imaging modalities. So we can both see if there is a lesion in both imaging modalities. But in CESM or contrast enhanced tomography, you can see if there's an uptake, there might be some it might be a suspicious lesion or malignant, since it will only have an uptake if there's a tumor growth.
We have another question from President Denise Chung. This is for Ms. Regina. She's asking, how common is a posterior NCS case?
Actually, the anterior NCS is a very rare condition. However, the posterior nutcracker syndrome is much rarer or rarer than the anterior NCS. I personally do not encounter the posterior NCS, and actually NCS are incidental findings only.
I guess we'll have two more questions or three more questions in the chat box, and then we'll proceed asking our panelists if they still have something to add. So this question is from Mogahid Zedan. And the question is, what are some limitations or drawbacks to using ultrasound or breast imaging compared to mammography? What factors should be considered when you decide whether to use mammography, ultrasound, or both for breast imaging?
Usually there is no limitation in there is a limitation in ultrasound if a patient has a breast implant. But if a patient do not have implants, we can examine the breast thoroughly. We can see if there is a mass or any calcifications. But if the patient have an implants, we are recommending that the patient should undergo an MRI procedure, because MRI is more sensitive with breasts that have an implant. That's all.
And I think we'll have the last question from President Selva. His question is, what imaging modality is preferred in a case of a pregnant lady for suspected lump in breast? Is it mammo or ultrasound? I guess he's asking regards your cases encountered when you have a pregnant woman. Yes, his question is, what imaging modality is preferred in case of a pregnant woman for suspected lump breast? Is it mammo or ultrasound?
It is recommended that the patient would undergo a breast ultrasound, because ultrasound is a non-invasive procedure Unlike the mammogram, it's have a radiation, ma'am.
So before I proceed with asking if there are comments from panelists, is there something that you would like to add? Maria Jordi, Miss Feliz, Miss Patricia, Regina, and Maria Teresa. And is there any more comments or questions from the panelists that we have tonight?
Yeah, hearty congratulations to all the 5 speakers. They did a very wonderful job. The ultrasound and mammography is good topics for today. The pictures and the videos they shown is very good. Their presentation shows their in-depth knowledge on the field. It's really heartening to see that ultrasound program done by radiographers in other countries. As such, in India, we are radiographers not allowed to do ultrasound. So it's happy to see the developments in the other side and the way they are handling the procedures in emergency also. So looking very good. Thank you for Philippines Association for organizing such a wonderful program. Thank you.
Thank you very much, President of the ISRT, President Salva Comar. So I guess if there would be no more comments and or questions from the panelists, I shall proceed with the closing ceremony, closing part of the program. So again, thank you very much to all our presidents, to all our invited panelists. The PART, Philippine Association of Radiologic Technologists, has just provided us with 5 young, very good speakers who have just shared to us very interesting discussions. Thank you so much to Feliz Nina Perez, Maria Teresa Zapata, Maria Jorili Mercado, Ma'am Regina Angelica Almazar, and Patricia Ann de la Cruz. We have learned so much from your interesting and important discussions. But in the interest of time, you have to cut from here to give way for the closing session. So I would like now to invite all of you. Let us all welcome Mr. Trong from the Vietnam Association of Radiologic Technologists to give us the invitation from VART for the next CPD Asia. Mr. Trong.
Thank you, Beaches. Dear colleagues, on behalf of Vietnam Association of Radiology Technologists, on behalf of President Thai Vang Lok, I would like to invite on CPD member to participate in the 27 online CPD program hosted by Vietnam on Sunday, July 30th, with the topic artificial intelligence in MRI. Thank you.
Thank you, Lee Tan Trong of Vietnam Association of Radiologic Technologists, inviting us on behalf of President Thai Van Loc. Again, on behalf of the PART, we say thank you for joining us in the 26th CPD Asia. We give thanks to the support of our presidents, to our sponsors, VT Healthcare Vietnam, also we are grateful to our 5 speakers, and most of all, we are sincerely grateful to all the member societies presidents, to our very hardworking CPD Asia team, and to all the registered participants who have made this 26th online CPD Asia program a success. We would like to see you again in the next CPD Asia. Again, I'm Peachy Luna, and I say thank you, everyone, and good night.
Good night. Good night, everyone.
Good night.
See you all.
Bye-bye. See you. Thank you, Pichi Luna.
Thank you.
Thank you, Pichi.
Thank you, everyone. See you next month.
Thank you, Ma'am Cora Ng, Lee Tan Trong.
Thank
Thank you,
you.
Sir Philip Chung.
Thank you all.
President
night.
Fernando Koch, 212, Nelson Wan, Sir Hidayat.
You're welcome, Pichi Luna.
Thank you, Sir
See you
Chung
next
Chun
time.
Yu.
See you next time with VART.
Putu Irma, thank you so much. President Denise.
You're welcome,
thank you so
Pichi.
much. And Sir Dexter Rodelas, maraming salamat po.